we can just record you just like nodding your head and just
sure.
pretending to do that. Yeah. Okay, cool. So I think we can just, Srishti, if you can share the
Yes.
slides, maybe he can start.
Yeah.
Uh,
Sir, I'll give you a cue of 3 to 1. That means your recording will be started. Yeah.
Now I can't see the
I think,
slides again. The slides have gone.
yeah, she'll put the slides
I'll
on.
just
Maybe you can just also be like, thank you, Dr. Mittal, for the kind introduction, and then just start the presentation.
Yes, I will do that.
Yeah. Okay. Amazing.
Sir, I'm giving a cue of 3 to 1 for you to
Hold
do
on.
that. No. Okay. Okay. I'll
Hold on. Come on. Hello, it's Peter. Yeah, not too bad. Yep. Oh. Yeah, what's she on at the moment? She's on Residronate, right? Right. Well, we would just transfer her to teriparatide. We wouldn't add in denosumab. Yeah, so it would be a matter of whether she goes on to teriparatide or romosozumab. What's her PTH? Is her PTH normal? Yeah. Okay. No, I think either of them would be fine as long as she's on an anabolic drug. Yeah, it would be good. And because she's transitioning from residronates, you don't need to worry about the combined treatment with denosumab. Yeah. Mm. Yeah. Yep. Okay. No, that's fine. Bye-bye. Okay, I've got my phone on silent, but
That's okay.
it
That's
comes
okay,
through.
sir. If in case you get a call, so we can cut that.
Yeah.
That is fine. So just one thing, your video is getting stuck in between.
It's getting stuck.
Yeah.
It was, now it's not, but when you were on the call, it was kind of getting stuck.
Oh, yeah, maybe that was something to do with the phone call. Yeah.
Are you on your Wi-Fi?
I am.
Okay.
Let me just change.
Yeah, no, your voice is cracking now. So I think
Network.
maybe if you can change your network, because again, your voice kind of got a bit cut.
So you're there? Am I audible?
I mean, I can hear you.
Okay. So his video is stuck then.
I think he's changing his
Yeah.
connection.
I don't know why. Could just to my mobile phone data. Why is it doing this?
Your picture is not. I mean, now I can hear you. I can hear you, but your picture quality is not clear.
Okay. I will try changing to a different system.
All right.
But it might go off the air a bit while I'm changing over.
No problem.
He's not there. He'll come, I think.
Hmm.
Also, we'll have to change the link for other speakers now.
तो ये वाला लिंक क्यों भेज दिया उनको स्पीकर्स को?
यार मुझे नहीं पता था कि स्ट्रीम यार्ड पर वही लिंक नहीं यूज होती है. मुझे ये अब भी पता
ठीक है.
है. I'll create another new link and send it to everyone.
Yeah, so it might be easier if you just send Dr. Ebling a new link and use this for the speakers.
I'll do that.
I
Okay.
mean, when he logs on, you can just send
No,
him a
no,
new
no, no.
link.
We cannot use this link again. No, we cannot reuse this link.
Okay, okay. ठीक है. Then we'll send another link to the speakers. That's not a big deal.
Hmm.
How is that now? How is my
Hello.
picture?
Yeah, seems okay. If you could just talk for 30 seconds so that we can just see the voice quality.
Okay. Yeah, testing. I'm about to record my talk for the Indian Bone and Mineral Society. Today it's Friday afternoon here in Melbourne.
Yeah, I think that seemed okay. Shrishti, was that okay?
No, because I couldn't see Sir talking. I could just see a static image of his. So one more time, if you can speak. One more time.
Well, I think the static image is the one that's down the bottom. I don't know how to get rid of that, but the one I'm
This is
seeing
fine.
is moving.
This
Yeah,
is
this
fine.
is fine.
This is fine. This is fine.
Okay, good.
So you'll have to upload your slides again. The same
I have
procedure present.
to do it again?
Yes, yes.
Okay. Are they, you can see them now?
Yes, I can see it. I can see it. I'm just adding it here.
Good, I can see them.
Yeah. Let me know if you're ready. We can start with I'll give you a cue then.
Okay. I'm ready when you are.
Okay, all right. 3, 2, 1, and start.
Thank you, Ambrish, so much for that kind introduction and also for the invitation to speak at the Indian Society for Bone and Mineral Research this year, which is also sponsored by the IOF and Alkem. It's really a great pleasure for me to be speaking here today. I'm going to be talking about advances in the management of vertebral fractures, and these are my disclosures shown here. What I'd like to discuss with you today is surgical treatment versus conservative treatment for acute vertebral fractures, in particular to examine the evidence regarding the efficacy and safety of percutaneous vertebroplasty and balloon kyphoplasty for acutely painful vertebral fractures. Do the benefits outweigh any harms? And is one form of vertebral augmentation better than the other? And for the second half of my talk, I'm going to be discussing whether anabolic therapy fits into clinical management of patients with vertebral fractures and the evidence for that from randomized control trials, and also the important topic of preventing vertebral fractures following denosumab withdrawal. So I was the co-chair of the second ASBMR task force report on the efficacy and safety of vertebral augmentation. And we were charged by the ASBMR to look at the effectiveness of interventions for acute vertebral fractures, namely kyphoplasty and vertebroplasty, because there is this concern that there is a strong placebo effect of surgical procedures. And as well, the natural history of pain in acute vertebral fractures is to diminish over time, say over 6 or 8 weeks. So these are the two types of vertebral augmentation methods that we studied: percutaneous vertebroplasty and balloon kyphoplasty. They differ slightly, although the approach to the vertebra is the same through the pedicle. With balloon kyphoplasty, a balloon is inserted into the vertebral body and inflated, and then the bone cement is put into the cavity that's created in the vertebra. So you can actually correct the kyphosis slightly, and the bone cement goes into that cavity. So the key questions that we addressed is, what is the efficacy and relative effectiveness of percutaneous vertebroplasty in improving pain, physical function, and quality of life? And what is the efficacy and relative effectiveness of balloon kyphoplasty in improving pain, physical function, and quality of life? And also, what are the harms of percutaneous vertebroplasty, including the possible risk of adjacent new vertebral fractures? And similarly, what are the harms of balloon kyphoplasty, including new vertebral fractures? So this is really the summary of what I'm going to present today. So this involved a literature search, and for vertebroplasty, we screened more than 6,000 abstracts and 33 articles were reviewed, and this led to 13 randomized trials and 1 quasi-RCT being included. Interestingly, the search for kyphoplasty, although it yielded fewer abstracts, about 3,000, we looked at 54 articles, and we selected the same number of randomized control trials and 1 quasi-RCT as well. Part of the literature search was also looking at exercise and bracing and physical therapy, but I won't be presenting those outcomes today. So the key outcomes we wanted to study in our literature review were the efficacy, namely effects on pain, disability, posture, function, quality of life, patient-reported treatment success, and safety, new vertebral fractures, and other adverse events. And other considerations we made were the timing of the intervention. It might be that if you gave one of these interventions closer to the time of the vertebral fracture, where the pain was higher, there might be a more beneficial effect. So these were the included studies for vertebroplasty, and it was actually part of a Cochrane review. And these were, as I said, 13 randomized control trials and 1 quasi-RCT met the inclusion criteria. But there were only 5 of these randomized control trials, with a total number of 535 patients who had a low risk of bias, in that the study was vertebroplasty versus a control, which was a sham procedure. So there were 2 prior randomized controlled trials published about 10 years before with 209 patients, and 3 newer randomized controlled trials with 326 patients. In addition, we looked at the other 8 randomized controlled trials and 1 quasi-RCT, but these were considered to be at high risk of bias and weren't controlled. And these largely compared vertebroplasty with standard medical care, but you'll note that the number of patients included in these studies was more than double that we found in the other placebo-controlled randomized controlled trials. So the key findings for vertebroplasty was that at 1 month, there was a small and clinically unimportant difference in pain favoring the vertebroplasty group. So the mean difference was 0.62, and that was on a scale of 0 to 10, but it was only identified at 1 month after the procedure and not thereafter. The mean pain was 5 points in the placebo group and 0.6 points better in the vertebroplasty group. So again, this is really probably not a clinically significant improvement in pain. Now, we looked at the effects of vertebroplasty according to symptom duration. So this was acute versus subacute pain, if you like. And this was examined in a subgroup analysis for outcomes of pain and disability at 1 to 2 weeks and 4 weeks after the procedure. And the data for acute fractures included trials that only included participants with pain less than or equal to 6 weeks, less than or equal to 8 weeks, and or less than or equal to 9 weeks or less as well as the participants with symptom duration of less than or equal to 6 weeks in 2 other trials. And even doing this, no important differences in outcomes were found when we adjusted for the symptom duration. Now, the effect of symptom duration on the outcome of pain, 5 trials with 378 or 71% of the participants with acute symptoms, including data from all 3 trials, including only participants with acute fractures and participants with symptoms for less than or equal to 6 weeks from the other 2 original trials, showed no difference at 1 to 2 weeks, but there was a mean difference in pain at 1 month of 0.25 on a 0 to 10 scale. And we thought this difference, again, it was small and likely to be clinically unimportant. There was a difference at 1 month. So it's also important to look at the differences between the vertebroplasty sham RCTs, and in particular looking at the sham procedure as well as the primary study outcomes. So these were the original 2 trials, Calms and Bookbinder in 2009, which were published in the same edition of the New England Journal of Medicine. And they had symptoms less than 1 year after the vertebral fracture, and 20% had symptoms less than 6 weeks in the Calms study, and 40% had symptoms less than 6 weeks in the Bookbinder study. Importantly, how the sham procedure was done is that the trocar was put through a skin incision down to the periosteum. Local anesthetic was applied to the periosteum, and the bone was tapped, and the bone cement bag was opened so the patient could smell bone cement. The primary outcome in this study was the mean pain at 1 month and the mean pain change at 3 months in the Bookbinder study. And there was no significant changes found by the procedure in either of these studies. And you can see that their pain at baseline was 7 out of 10, so quite severe pain. Now, the other study was the Clark study, which was published in The Lancet. It had 120 patients, and the time since vertebral fracture was less than 6 weeks in all 120. Now, these patients just had subcutaneous numbing. They didn't have introduction of local anesthetic around the periosteum, and they had slightly greater pain at baseline. And the primary outcome was a percentage with a meaningful pain reduction at 1 month. And this was significant, with 44% for vertebroplasty and 21% for the control procedure. The other study was Furinescu from 2018, 180 patients. The time since vertebral fracture was a median of 6.5 weeks. Again, periosteal numbing was the sham procedure. The pain score was 7.7, and they looked at the primary outcome at mean pain at 1 day, 1, 3, 6, and 12 months, and they didn't find any significant difference. The Hansen study was a smaller study with time since vertebral fracture being less than 12 months. Again, periosteal numbing was the sham procedure. The pain scores were similar at baseline at 7.5 out of 10. And the mean pain at 6 hours and then weekly to 3 months and 12 months was reduced in the vertebroplasty group in this study. So 2 out of the 5 studies had significant reductions in pain early on. And this just shows the data from the VAPOR trial, the one published by Clark in The Lancet. And again, this didn't include periosteal numbing in the sham procedure group. And here we can see that in the vertebroplasty group, the percentage of patients with a pain score less than 4 out of 10 was higher at day 3, day 14, month 1, and month 3 and month 6. So this led to a lot of interest and whether vertebroplasty should be taken up again after the initial trials were done about 11 years before. So this is just a summary of harms, and these are the data for new radiographic vertebral fractures, vertebroplasty versus placebo, sham or standard medical care. And if you see that this overlies the confidence interval of 1, so there's really no effect here. And then if we look instead at the vertebroplasty versus standard medical care, which were open randomized control trials, if we look at the outcome of pain, and based on data from up to 6 trials, the analysis favored the percutaneous vertebroplasty group, who had greater improvement in mean pain compared with usual care at 1 month. And the mean difference was 3.3 out of 10. And similar results were observed at 1 and 2 weeks, and at other time points up to 1 year. Now, based on data from up to 5 trials with 494 participants, there was also an improvement in disability that favored the vertebroplasty group at all time points, and the mean difference at 1 month was a score of minus 6.38 in the vertebroplasty group, which was a reduction in disability score in 3 trials with 378 participants. But I think it's really important to note these studies had a high risk of bias because they didn't have a sham procedure, and open trials versus standard medical care are therefore likely to have overestimated any benefit of percutaneous vertebroplasty. So we also did our own meta-analysis and systematic review looking at kyphoplasty, and this was really the first ASBMR task force report. This study was conducted by a PhD student of mine, Alexandra Rodriguez. And the key findings that no studies compared kyphoplasty with the sham procedure as placebo. So this is very different to the 5 vertebroplasty trials that I've described. However, compared with non-surgical management, kyphoplasty was associated with statistically significantly improved pain, disability, and quality of life for up to 12 to 24 months. That diminished over time. And for instance, the visual analog scale for pain at 1 month was 1.8 points different in the kyphoplasty group and 1.5 points less at 3 months. Similarly, there was an improvement in the RMDQ measurement for disability, which was on a scale of 0 to 24, with a 4.2 point reduction at 1 month and 3.7 point reduction at 3 months in the kyphoplasty group. But compared with other active interventions, and there were some other studies that were done looking at kyphoplasty compared with vertebroplasty or other vertebral stenting procedures, for example, kyphoplasty didn't really significantly improve clinical outcomes. So there was no benefit over the other procedures. But there was no increased risk of incident symptomatic vertebral fractures or other serious adverse events associated with kyphoplasty, but we couldn't exclude a clinically important increase in risk due to the small number of events. So these are the results of back pain in trials of vertebroplasty versus kyphoplasty. Again, there was no difference shown here. So again, our task force recommendations are on benefits, the efficacy of percutaneous vertebroplasty on outcomes of pain, physical function, and quality of life was that percutaneous vertebroplasty provides no demonstrable clinically significant benefit over placebo or sham procedure, and results did not differ according to the duration of pain. We thought the quality of evidence was high to moderate, and the strength of the findings was based on 5 randomized controlled trials that compared vertebroplasty with placebo, with follow-up up to 2 years. So a high strength of findings and a high to moderate strength of recommendation. The efficacy of balloon kyphoplasty on outcomes of pain, physical function, and quality of life showed a small clinical benefit over non-surgical management, percutaneous vertebroplasty, vertebral body stenting, or Kiva. But this quality of evidence was low, and there was one randomized trial versus non-surgical management with 300 patients and a follow-up period of 2 years that we largely based this on. So the strength of our recommendation was weak based on the low quality of evidence that was available to assess. What about the harms? We thought it was uncertain whether percutaneous vertebroplasty increased the risk of incident or radiographic vertebral fractures or other serious adverse events. The quality of the evidence was moderate, and we had 8 randomized controlled trials, placebo control in 4 trials, and usual care in 4 trials with 804 patients. And the number of fractures was 203 and 57 SAEs. So we thought there was moderate strength to our conclusion. And with balloon kyphoplasty, there was less evidence. So there was only one randomized trial versus non-surgical management with 223 patients and case reports. And there were only 101 fractures and 157 SAEs with a follow-up period of 2 years. So the evidence quality was low, and our recommendation was therefore weak. So obviously, this created a lot of interest. These articles were published in the JBMR and accompanied by an editorial about whether it's time to stop or pause vertebral augmentation. In the United States at that time, there had been some bad press about vertebroplasty, and kyphoplasty was the major form of vertebral augmentation done in the United States. And because of these systematic reviews and reports and editorial, as well as a New York Times article that I was interviewed for by Gina Colata, this practice has been reduced in the United States. And I'd be interested to find out how common it is used in India. So the next part of my talk is really talking about anabolic drugs and their efficacy for vertebral fractures. So we've been lucky that we've had head-to-head studies of anabolic drugs versus anti-resorptive drugs. This looks at the incidence of new vertebral fractures for teriparatide used for 24 months compared with risedronate. And we know that risedronate reduces vertebral fractures by 45% already. So when we're looking at these results, we have to remember that this is not against placebo. This is against an active drug that reduces vertebral fractures. So we can see at 24 months that teriparatide reduced vertebral fractures by 56%, with an absolute risk reduction of 6.6%. And this reduction was also seen at 12 months, and there was a 48% reduction in relative risk at 12 months as well. Unfortunately, that's not coming up when I press the advance button, but you can see the relative risk expressed there, and that was significant. The other study that was a head-to-head study was the ARCH study, which compared romosozumab versus alendronate for 12 months, followed by alendronate. And this study went for more than 36 months because it was event-driven. And we can see that over 2,000 patients received either alendronate or romosozumab, 210 milligrams subcutaneously every month for the first 12 months. And then in the open label period, everybody received alendronate. Now, this is the effect on new vertebral clinical and non-vertebral fractures for romosozumab versus alendronate for 12 months, followed by alendronate. And the story is very similar to what we saw in the Vero study with teriparatide compared with the risedronate, we can see this almost 40% reduction in vertebral fractures at 12 months, and at 24 months, there's a 48% reduction in vertebral fractures with the sequence of romosozumab for 12 months, followed by alendronate for 12 months. And if we look at the first clinical fracture in time to event analysis, we can also see that there's a significant reduction in clinical fractures, and that begins probably at about 24 months. And we can see that the first non-vertebral fracture in the time to event analysis is also significantly reduced by the sequence of romosozumab to alendronate. And that was also shown for hip fractures. So all of the fractures that we think about in osteoporosis, vertebral fractures, clinical fractures, non-vertebral fractures, and hip fractures were reduced more by the sequence of romosozumab to alendronate than alendronate alone, giving us powerful evidence that this anabolic drug is better than the most widely used anti-resorptive drug, alendronate. This was also studied in the balaparatide study, and a similar design to what we've seen with the ARCH study. The active and active extend study was either placebo or abaloparatide, followed by abaloparatide and alendronate, or placebo and alendronate. And you can see that there's a dramatic reduction in vertebral fractures by abaloparatide of 86% compared with placebo. And then when alendronate is substituted, there continues to be a reduction in vertebral fractures. And the same is true for non-vertebral fractures and also for major osteoporotic fractures and clinical fractures. So again, very similar data with abaloparatide followed by alendronate versus placebo followed by alendronate on fractures. The other thing that was presented at the ASBMR meeting earlier this year in September was a reanalysis of the FRAME study. As you know, the FRAME study was, and FRAME Extend study, was the treatment sequence of romosozumab versus placebo, followed by denosumab. So what they did in this study was look at a 2-year treatment sequence of romosozumab followed by denosumab, compared with the 2 years of the most potent anti-resorptive, denosumab only. So this was comparing year 1 and 2 of the romosozumab denosumab arm, and then year 2 and 3 of the placebo denosumab arm. And when they did this to try and work out if romosozumab followed by denosumab was better than denosumab alone, they found that the BMD gains were 2-fold higher at both the spine and hip sites. And there was also a significantly reduced new vertebral fracture incidence of 57%, and a lower incidence of clinical non-vertebral and hip fractures, but these differences were non-significant, where the only significance was the reduction in new vertebral fracture incidence. So these data indicate the beginning treatment with romosozumab followed by denosumab provides a benefit beyond treatment with denosumab alone on vertebral fractures. So again, these data help demonstrate that romosozumab should be considered as an initial therapy in patients at high risk of fracture. The last part of my talk now is going to be just focusing briefly on the problem with vertebral fractures after discontinuing denosumab. And this was shown in the FREEDOM and FREEDOM Extension study. And vertebral fracture risk in this study was assessed in patients who discontinued either placebo or denosumab in the FREEDOM study, or who stopped denosumab in the FREEDOM Extension study. And all these patients had to have a follow-up at least 7 months after their last dose of denosumab or placebo. Now, what we see below is that fracture risk increased upon stopping denosumab, but not to those to levels greater than those seen in stopped placebo, with the exception of multiple vertebral fractures, which was numerically higher in the group that stopped denosumab compared to the group that stopped placebo here. This wasn't statistically different, but it was numerically higher. And this raised the concern that patients who discontinue denosumab might be at risk of multiple vertebral fractures. And certainly there are a number of case reports and case series showing that this is the case. So from the Freedom and the Freedom Extension study, there were significant predictors of off-treatment multiple vertebral fractures. And having a prior vertebral fracture is the strongest predictor of off-treatment vertebral fractures. And the other predictors were off-treatment duration and the loss of bone density from the total hip, although that wasn't significant when more patients were included. So the most important thing was having a prior vertebral fracture and the off-treatment duration per year. You can see the odds ratio is 3.9 for having a prior vertebral fracture and 1.6 per year for being off treatment. And why might this be the case? Well, vertebral fractures can alter the spine curvature and biomechanics, and they alter the loads on other vertebrae in ways that may predispose to additional vertebral fractures. So we call this a vertebral fracture cascade, and that's because there's regions of increased loading adjacent to a vertebral compressed vertebra, and as well as that, regions of alleviated loading can lose bone due to stress shielding, which may increase their fracture risk during forward bending. So we have one vertebral fracture here, but we can get more in the adjacent vertebrae. So how can we prevent this? Well, I think it's really important if any patient stops denosumab for whatever reason, that they should go on to some alternative form of treatment. In this study, patients were treated with 12 months of denosumab and then changed to 12 months of alendronate. And we can see this with this short duration of preceding denosumab therapy, that there was on average maintenance of bone density at the spine and total hip in the next 12 months when transitioning to alendronate. However, I think there is cause for concern because this is another randomized controlled trial that was published in the Journal of Bone and Mineral Research. And this is a complicated slide, but basically these patients were given a zoledronic acid infusion either at the time of the missed dose in the blue, or 3 months after the missed dose in the red, or according to a very high CTX level in the green. And it doesn't really matter when you give the denosumab, the zoledronic acid infusion after stopping denosumab. There was still bone loss of about 4 or 5% at the spine and 4% at the femoral neck and total hip when giving just one zoledronic acid infusion. So this has led to some European recommendations that if patients stop denosumab, that they should have a zoledronic acid infusion at the time of the missed dose of denosumab. And then you could measure the CTX level 3 months after that. And if it's still high, give another dose of zoledronic acid. So it's likely that more than one infusion of zoledronic acid is needed to prevent bone loss after denosumab withdrawal. But the studies that have looked at vertebral fractures show that if you give a bisphosphonate after stopping denosumab, the likelihood of having vertebral fractures in observational studies anyway is reduced. So I think it's important to give a bisphosphonate. The other thing that I'd like to mention regarding denosumab withdrawal is that if a patient has had vertebral fractures at this time, that's really an absolute contraindication to doing a vertebroplasty or kyphoplasty, because it has been shown in some case series that if patients do have a vertebroplasty in the setting of denosumab withdrawal, they're very likely to develop adjacent vertebral fractures. So I think that's important to remember. So if somebody has vertebral fractures following denosumab withdrawal, vertebral augmentation with vertebroplasty or kyphoplasty is really a no-no. So I hope you've learned something today. It's really been a pleasure talking to you. And what I think, and Ambrish will be able to comment on this, is that the optimal management of painful vertebral fracture is uncertain. The routine use of vertebral augmentation is not supported by current evidence. And when it is offered, the benefit may be greater if the onset of pain is less than 6 weeks. But patients should really be fully informed about the current evidence. I think it's really important to know that anti-osteoporotic medications, even anti-resorptive agents, reduce the risk of subsequent vertebral fractures by 40 to 70%. So we know that denosumab and zoledronic acid reduce the risk by 70%. However, we now have data that anabolic drugs are more effective at reducing vertebral fractures than anti-resorptive drugs, and that includes teriparatide, abaloparatide, and romosozumab. And the use of bracing in reducing pain immediately after a vertebral fracture is not really supported by current evidence. We found that exercise may improve mobility and may reduce pain and fear of falling. However, the use of exercise to improve other outcomes is not supported by current evidence. So I'd like to acknowledge my ASBMR task force co-authors, and this was an international team of orthopedic surgeons, interventional radiologists, epidemiologists, endocrinologists, and rheumatologists, and other experts who had no conflicts of interest. And this is just to show you where I work in Melbourne, and you'd all be welcome to visit if you're in Melbourne at any time. It's really been a great privilege to speak to you today. Unfortunately, because the time of the question session is at 3:20 a.m., I won't be able to stay for the questions, but I have briefed Ambrish about some comments to make and some questions that you might like to ask. But thank you very much. It's been a pleasure speaking with you today. And I look forward to coming back to India and meeting you all in person one time soon. Thank you.
Thank you so much.
So that was okay?
Yeah, it was great. I think in the middle, I think your internet was going off. So a few times there was a little bit of your picture getting stuck while talking, but we could still hear the echo. And a couple of times I noticed the audio also kind of got stuck, but it's okay. We'll manage that.
I'm sorry about that.
No problem, no problem. And we kind of overshot a little bit as to the time limit. Is there any part of this, do you think, that we could cut a little bit, or should we use the whole thing? What do you think?
Yeah, the first part, probably there was one slide that didn't work. That could be taken out. It's a little bit hard to cut.
That's okay. That's okay. We'll manage then. We'll play the whole thing. We'll reduce the panel discussion a little bit. I think it's fine.
Yeah. Okay.
Okay. And if we could just, have you just for a minute, maybe just like nodding your head and listening, we could do that one recording. And if you could also just say a line thanking the other speakers, the panelists of this program. So I could just write down their names here.
Yeah, I'll do that.
Okay, so I'm just writing it on the chat.
Okay. Yep.
So I have written the names.
Yeah, I can see
Uh,
this.
Shantaram Shetty is how you pronounce it. Thomas Paul is obviously easy.
I
And
know Thomas.
Rajesh. Yeah, okay,
I know
great.
I know them all except the first
Okay,
one.
perfect. Okay, perfect. Shantaram Shetty, yeah.
Shantaram Shetty, Thomas Paul, and Rajesh Malhotra.
Hello.
Yep.
Sir, if you may say the names again, thank you to Professor Shantaram
No, first,
Shetty.
Srishti, were you recording him nodding his head right now, or were you just waiting for the names?
It has already been taken. While he was talking to
That-
you, we have captured
Okay,
that.
okay,
Oh,
okay,
okay.
great.
So what you'd just like me to now
Just the
you'd like
names?
me to thank the other panelists, and
Yeah,
shall I thank Ambrish as well for
yeah.
inviting me? Yep.
Yeah, no, so I think what you said earlier was thank you. Before you started your talk, you said thank you, Ambrish, for the kind introduction.
Yep.
And
Okay.
maybe you can just say that again, and you can just say also thank you to Dr. Shantaram Shetty, Dr. Thomas Paul, and Dr. Rajesh Malhotra for being part of this panel. Something like
Yep.
that. Yeah.
So thank you, Ambrish, for inviting me today. But also, I'd like to thank the other panelists who are here today, Professor Shantaram Shetty, Professor Thomas Paul, and Professor Rajesh Malhotra. I know you very well, and I'm just sorry that I can't be there in person with you today.
Yeah, I think that was okay.
Okay, I can do it again if you want.
No, I think that was fine. Srishti, was that fine?
Yeah, yeah, it is fine. It is fine.
Great. Well, that was easy, wasn't it?
Very easy. Thank you so much for your time. It was a
It's
pleasure.
a pleasure. And nice to
And
meet you,
yeah,
Nilesh.
and
And
look forward to seeing you when you come to India.
okay, look forward to that.
Yeah. Okay. Bye bye.
Bye bye.
Thank you. Bye.